Thank you very much, Julie, for your kindly presentation. And only thank you, Kevin and Patrick, for inviting me to this conference. And of course, thank you for coming to my talk. I will start presenting a little bit with what is iSears. Well, first of all, I don't have any conflict of interest. No funding has been received from pharmaceutical companies or for-profit companies for the research projects presented. All financial support for the research projects has been provided by private donations, non-profit organizations, and public funds. And no donors have been involved in design, development, data analysis, or any other phase of the research processes. So I will introduce in iSears a little bit. iSears works in the navigating in the challenges of the globalization of traditional indigenous medicines. We have several programs. We have one program in which we inform and give support, for example, for people having past challenging experience with ayahuasca or other plant medicines. We also do research and innovation. We do advocacy. For example, we defend people, and we work with lawyers that are defending people who have having troubles for carrying with them ayahuasca or other plant medicines. For example, we worked in Mexico last year with different cases where at least 3 indigenous people were in jail, and they were released after our participation. And we try to build community also doing ayahuasca conferences and other things. We work from 3 principles. The first one is that we think that public policies should be based on human rights and social justice. We promote bottom-up social change, and we work from an evidence-based approach. And we also are members from the Economical and Social Council from the United Nations, where we used to organize side events in the different commissions, for example, in the Commission on Narcotic Drugs, or in some commissions regarding human rights. Well, I am the scientific researcher, the scientific director in research and innovation. We have at least 3 lines of research, one with medical cannabis, another one with ayahuasca. We are the leading research group on ayahuasca with my colleagues Rafael Guimarães dos Santos and Jaime Hayek for the University of Sao Paulo and Miguel Ángel Alcázar from the Autonomous University of Madrid. And we also have a line of research with Ibogaine. We have just finished last week a clinical trial where we administered Ibogaine to people that were in Methadone Maintenance Programs, and I will dedicate the last part of my talk to present the preliminary results. First of all, what is Ibogaine? Ibogaine is the active principle or one of the many alkaloids that are present in the plant Tabernantha iboga. Tabernantha iboga is a plant that grows in some areas in the rainforest of the equatorial Africa, mainly in Gabon and Equatorial Guinea. And the root bark contains between 1% and 3% of ibogaine. There are some preparations of the root bark, for example, the total alkaloid extract that contains approximately between 15% and 40% of ibogaine, or a total alkaloid precursor that contains around 80% of ibogaine. What we use and what is usually used in clinical trials and in research is ibogaine hydrochloride that has between around 99% of purity. Before that ibogaine came to West, iboga was used by in some mysterious cult. The most known is the Bouito cult in Africa. That is practiced by different ethnias. Probably the first ethnia that used iboga were the Pygmies. Probably the Pygmies learned to use iboga because they saw how gorillas used to take iboga. The gorillas in Africa used to take iboga, like other animals in the animal kingdom used to take other psychoactive drugs. And other cultures in Africa learned to use iboga as an element of their traditional medicine, and some of them are the fang or the mitsogo. Well, what is the use that the Bouito people use of iboga? In animistic societies, when someone becomes ill, it's not because the illness belongs to the person. When there is an illness in an animistic culture, it's because there have been a distortion between the alignment of the individual, the community, the ecosystem, and the geographical territory. All these four levels are the same in animistic cultures. So when there is a problem, the problem is not of the person. The problem is also of the community, of the environmental, and the geographical territory. So if you destroy the geographical territory, these cultures don't have access to their medicinal plants, and they don't have access to the rituals that strains the bonds of the community, and at last it's impossible to restore the equilibrium. So and this has happened also in the Amazonia, for example, with ayahuasca. So when there is a problem in the individual or in the community, all the community get involved in the healing process. So the rituals involved in iboga for the Bouito people, but also in the Amazonia for other indigenous cultures, involve or consists in involvement of all the community in the healing process. In the case of Bouito, this healing process used to take 3 days and is led by women. I also would like to mention that medicinal plants like iboga in Africa or ayahuasca in the Amazonia, first of all, is the main medicine, or is above all a medicine, but also can serve as a tool to fight against colonization. The Bouito people probably start to use iboga as a reaction against the colonization of their territories. This also can be shown in some parts of the Amazonia, for example, in the Putumayo in Colombia. Well, iboga meets West, and I will go quickly with this part because you can read it in too many books and too many articles. Ibogaine was isolated in 1901, and well, was marketed in France with the name of Lambrenne. Lambrenne is a town of Gabon. Ibogaine was used in the MK Ultra project of the CIA in the 50s, and there is a patent from 1957 that is a very important data because the clinical trial that we perform is focused in trying to obtain evidence regarding this patent that after 1957 nobody tries to prove if what was said in the patent was true. This patent was for using ibogaine to reduce tolerance in people that were using opioids because of chronic pain. Well, opioids develop a very rapid tolerance, so you have to increase dose, and if you increase the dose, there are more probabilities to become on an overdose. So if you have a product that in some way reverses tolerance, you can keep using opioids in a more safe way. Well, nobody used since then Ibogaine in order to reduce tolerance to opiates, and the next step in the story is the serendipitously discovery of the anti-addictive properties of Ibogaine by Howard Lotsof. I think that this story is very well known. Howard Lotsof was a heroin user, and he obtained some Ibogaine, and with his friends took Ibogaine, and in 1 hour or so, suddenly they saw how the withdrawal syndrome disappeared. So, in a casual way, Lotsof and his colleagues discovered this effect not only to reduce tolerance, but to eliminate the withdrawal syndrome. In this moment, started a peer-to-peer movement in which people that were heroin users were initiating to other heroin users Ibogaine in order to quit off from heroin. Well, in the 50s and 60s, Claudio Naranjo used and Leo Ceff also used Ibogaine, and there happened some other things. In the 1993, started a first clinical trial that was stopped because there were some publications regarding the eventual possible neurotoxic effects of Ibogaine. Anyway, Ibogaine is not controlled, but the psychotropic treaty of the United Nations, of the Treaty of 1971, and it's only scheduled in some countries, like US, France, and Belgium, and some other. And this is the official story. That is the story that the North American researchers told us. But there is an unknown story about Ibogaine because it was not wrote in English. It was wrote in other language. And here there is a gap that is very interesting, and I will tell you for the first time to you. One of my PhD students, Jenny Sonia, did a research in all the former literature in different languages, in Spanish and in French, where Ibogaine appeared. And Ibogaine was marketed in France. At least there were 4 or 5 pharmaceutical companies that marketed Ibogaine. Ibogaine was the first psychedelic, the first hallucinogen that was marketed in the world since the 20s of the last century. And probably the most interesting thing, Ibogaine was used for many diseases like influenza, convalescencia, neurasthenia, and other diseases. But in fact, it was not Howard Lotsof who discovered the anti-addictive effects of Ibogaine. It was a medical doctor, a Mexican doctor, named Enrique Aragon, who treated for the first time in 1920 a patient with alcoholism for quit off, a woman for quit off from alcoholism. You can read the whole story in the journal Medical Humanities, that all these stories now under review. Regarding the neuropharmacology of Ibogaine, Ibogaine has a very complex pharmacology. Ibogaine touches almost every neurological systems, neurotransmitter systems. It release neurotrophic factors, touch opioid receptors, touch serotonin receptors, binds 5-HT2A, that is the receptor where all the classic psychedelics binds, but also touch noradrenergic receptors, and so on. Ibogaine is what in pharmacology is called a dirty drug, a dirty substance, a substance that touches almost everything. And in the classical models of pharmacology, the dirty drugs are not well shown. But because in the classic pharmacological model, there is an intent of trying to find specific molecules that touch one system without touching anything else. But this is a fantasy. For example, the inhibitors of the selective inhibitors of the recaptation of serotonin are not selective at all. But this is something that the pharmaceutical companies don't want to recognize. What happens with Ibogaine, we don't know why reduce tolerance and eliminate withdrawal syndrome. We know that that has this promiscuity effect. We have been studying depth this concept. In cannabis research, the name is entourage effect, but this term is not very accurate. We think that the more accurate term is polypharmacology. But although we have this drug, that's dirty drug, that has this pharmacological promiscuity and that touches almost everything, between all the psychedelic drugs that we know, this is the only one that has a direct and causal relationship between the effect and the symptoms that want to eliminate. For example, with psilocybin or with LSD, they are unspecific substances. They induce this altered states of consciousness that can be used to cure, but also can be used to other things. And in fact, it's necessary to do psychotherapy in order that this psychological effect serves for something or had a final psychotherapeutic effect. But Ibogaine, no. If you administer Ibogaine to someone who is with a withdrawal syndrome, you eliminate in 30 minutes the withdrawal syndrome. Regarding the subjective effects, again, there were not any studies exploring subjective effects, and with my other colleagues at ICERS, Dr. Maya Kohek, that also did her PhD with me, we interviewed 20 people who have experience with Ibogaine, and 10 of them patients, and 10 of them patients that were also Ibogaine providers in order to explore the subjective effects. Well, you can see the different dimensions that we found, and regarding the visuals are very different to classical psychedelics. Produce visions of ancestors and entities, scenarios and landscapes, and horrific scenarios. The ayahuasca experience is not pleasure at all. Also, it produced transpersonal experiences, and I think that the more important subjective effect is the induction of autobiographical and interpersonal experience, that it allows to work psychotherapeutically with patients. Well, we explore also the adverse effects in other paper, because Ibogaine, contrary to classical psychedelics, also has a more toxicological profile. It's necessary to monitor carefully patients when they are under the effects of Ibogaine because of the eventual cardiotoxicity. And this don't happen with classic psychedelics like LSD or psilocybin. Well, the preclinical evidence is also contundent and clear regarding the anti-addictive effects of Ibogaine. According to studies, the alkaloids from Iboga reduce self-administration of morphine, cocaine, methamphetamine, alcohol, and nicotine, and reduce the morphine withdrawal syndrome. And there is evidence of efficacy in a total of 11 independently published replications in rat, mouse, and primate. Very low likelihood of being explained based on the placebo effect. There is probably an effect on dopamine fluctuation in the nucleus accumbens. And as I told before, Ibogaine touches multiple neuroreceptors systems. In 19 I don't remember the exact date, we published this revision, where we review all the different studies that were published with Ibogaine. I was preparing the protocol. The preparation of the protocol took almost 10 years. I started thinking about doing Ibogaine research in 2010. And until 2020, we were not able to start with the Ibogaine protocol. If you do a research career, you have to be patient with everything, and to have a very high tolerance to frustration. That is my case. I give too many rounds. I was not an expert on Ibogaine. I have to learn about Ibogaine. I have to read everything of Ibogaine. I have to interview. But since Ibogaine has this toxicological profile, always a little bit scared to work with these complicated drugs. But I decided to go ahead. And in all this previous literature, Ibogaine was used to treat methadone dependence in many studies, and in a very higher doses, from 800 milligrams until 1.2 grams, that are very, very high doses. And in fact, people have died because of very high doses. As a pharmacologist, I also wonder, well, nobody tried with low doses of Ibogaine. And I was in communication with Claire Wilkins. She is visiting Barcelona and came to the office one day, and I asked her, did you ever use a very low dose of Ibogaine to treat someone? And she said, nobody have used a very low dose, but I have a patient that is with doses of 100 milligrams, taking once a month, and have very, very dominated the withdrawal syndrome. So I said, well, let's go with a low dose. I had a friend, a very close friend, that was for 17 years using methadone, and it was impossible for her to quit off. And she was waiting to start in this project, and this project that never started. When will they start this project? I don't know. I'm working on it. So after 3 years, she told me, well, I don't want to wait anymore. Why don't we go ahead by ourselves? And I said, okay. So we rent an electrocardiogram. In Spain, it's not a crime to possess and use drugs. And in Spain, Ibogaine is not scheduled. So she came to my house. We rent an electrocardiogram. We built a medical team and start with we see stop using methadone, and when started the withdrawal syndrome, it was like magic, with 100 milligrams, 150 milligrams of methadone. That is a very low dose. She was in the opioid withdrawal scale in a 0.9 from 10, and in 1 hour, completely disappeared. After 5 hours, the withdrawal syndrome become again. What happens with methadone is that methadone has a very half-life, and the half-life of Ibogaine cannot counteract this very half-life of methadone. So when withdrawal effects become again, instead of having 50 milligrams of methadone, that is the dose that she was using, took 25 milligrams. And the withdrawal syndrome disappeared. We find, for the first time, that what Ciba Pharmaceutical patented was right. Ibogaine was able to reduce tolerance and to eliminate temporarily the withdrawal syndrome. She was with 25 milligrams of methadone during some days. She stopped using methadone, and again the withdrawal syndrome appeared, and we increased the dose to 300 milligrams. And the withdrawal syndrome disappeared during more time, and we keep doing this process, reducing the dose of methadone and increasing the dose of Ibogaine. And after the fourth dose, there were no any withdrawal syndrome at all, and after 4 years, he's completely free. So I have clear what I should do in the protocol. I already have the methodology. So we implement this protocol in our project. But comparing one group that will receive just 100 milligrams every week, and the other group will increase the dose, 100 milligrams every time. So this is a double-blind, controlled clinical trial, randomized, and well, with all the standards for a clinical trial. And this is the schedule of the protocol. There are 6 sessions. In every session, we administer 1 dose of Ibogaine. Usually, patients stop using methadone on Monday, and usually it takes 24 hours in order to appear the withdrawal syndrome. People used to take methadone once a day in the morning. So on Tuesday, when they start to feel the first withdrawal effects, administer the dose, and every week we are reducing the dose of methadone. We obtain the Ibogaine from Vacanga africana. There is a very sustainable problem with Tabernante iboga. But you can obtain Ibogaine from Vacanga africana that has vacagnina and do a semi-synthesis. And we have an electronic database that is aligned with the most strict standards of quality. This is after 100 milligrams. All the patients reduces to the half their dose of methadone. The withdrawal syndrome was interrupted between 15 and 24 hours. One patient experienced symptoms of the withdrawal syndrome after 6 hours post-Ibogaine, and another patient after 10 hours. And we found an unexpected result, that some patients stop also using tobacco and alcohol. I have a friend that says that Ibogaine is the worst drug of the world because quit you the desire of taking drugs. No? These are the different doses or reductions at every moment for every patient. Not all the patients finish the treatment because Ibogaine has a very secondary effect that produces insomnia, and some patients don't tolerate this. We don't know in which arm, because I had no time to prove the blind, because the last session was last Tuesday. But I died of desire to go to a hospital and break the blind in order to see what happened. There were not any adverse side effects, serious side effects. The most common ones: tinnitus, insomnia, asthenia, somnolence, tremors. But all subjects reduce, as I said before, not all of them finishes the treatment, but just all of them reduces the dose of methadone in some way. Also, most of them finishes the treatment. Well, regarding the QTC prolongation, that is the thing that was more problematic, because methadone also prolonged the QTC and Ibogaine prolonged the QTC. Well, the known patients passed the clinical limits. And well, for finishes, this is the report of the first patient. After 15 years of taking my daily dose of methadone, I was a bit skeptical about the Ibogaine, but the truth is it was a complete success. I was able to interrupt my methadone intake without suffering withdrawal symptoms. In the first few days, when I didn't feel the need for opioids, I couldn't believe it. Ibogaine gave me my freedom back. My life has improved significantly since then, not having the constant fear of withdrawal symptoms. Wonderful for someone who has lived with that for many years. Thank you. Yeah, thank you. Thank you to the clinical team. We work also with, my colleagues in the Universidad Autónoma de Madrid and my colleagues in Brazil. We have another clinical trial in Brazil with Rafael Guimarães dos Santos and Jaime Hayek for using Ibogaine for the treatment of alcoholism. That, in fact, is the more problematic drug. Well, we have a problem, or you have a problem here now with fentanyl also, I think. And, well, all the different institutions that were involved in the study, thanks to all of them, and thank you very much for your attention.
Hi, you want to stay for some questions? If anybody needs to scan the QR code to get on Slido, to ask your questions. I imagine you covered this, but I think it's just worth repeating again. Like, how are you administering Ibogaine? Is it oral or IV? Are you doing a flood dose, or are you gradating? Like, if we missed that, I'm sorry, but it's coming up as a question.
Yeah. No, orally.
It's oral.
We start with 100 milligram. That is a very low dose. And, well, it's incredible, because even a very low dose, like 100 milligram, is able to stop withdrawal syndrome and even to reduce tolerance. But 100 milligrams is so low dose that cannot counteract the long half-life that has methadone. Methadone is a very complicated substance, because the withdrawal syndrome is terrible. We had the epidemic, the heroin epidemic in the 90s and in the 80s. So now we have too many people that are under methadone maintenance programs since then, and that after 10, 50, 20 years, they were not able to quit off from methadone. For some people, the usual method to quit out from methadone is to reduce little by little, no? The dose of methadone. But we don't know why. For certain people, when they reach to a certain dose, even half a milligram, again produce the withdrawal syndrome.
Right.
So it's with these people with what we have been working.
Understood. We have a question whether there's been any research looking at Ibogaine specifically with smoking cessation or tobacco nicotine addiction. Are you seeing that?
Well, in fact, we have a protocol to use Ibogaine in the treatment of nicotine addiction.
Good.
But for me, I know that tobacco addiction probably is the worst epidemic regarding with drugs, also with alcohol. But we were discussing this a lot, and it's a complicated drug. I think that there are other ways to quit off from tobacco, even doing nothing, just don't smoking. But probably to people who has problems to quit from tobacco, well, I would like also to say that Ibogaine is not a magic bullet nor for methadone, nor for anything, because drug use is a very complicated thing that has not to do only with pharmacological issues, and probably there are extra pharmacological issues that are more important in the maintenance of a dependence. There are too many determinants, social, political, economical, and determinants that are involved in drug abuse. So to look drug dependence from the point of view of biomedicine is completely wrong, because there is a clear example that I told you yesterday to some journalists. In the Tsar, in the Russian Empire, it was forbidden to use coffee. And people used to use coffee in underground coffee shops, and if the police catch him, they cut their hands. And there was a very problem of public health because of the coffee. And now,
right. And now everyone drinks coffee.
And like this, there are too many other examples. So,
yeah.
But what Ibogaine allows is to open a window of opportunity in which people are without craving, without withdrawal syndrome, and without tolerance, when from a psychosocial perspective, it can be grown. It can be worked. For example, and I'm finished. In our hospital, we have a very well-connected services with the community and a very strong services of harm reduction. And combining bonds with community and interventions from the harm reduction programs probably is one of the reasons that in the follow-up, people keep free from methadone.
Right. I mean, the community support, the peer support is all part of it. Two quick questions. One is, can you talk about magnesium a little and whether magnesium may reduce some of the cardiotoxicity risks, number one? And number two, do you need to adjust dosage woman versus man?
Well, I have to do the statistical analysis.
Okay. So maybe on the gender dispute. I mean, is it your intuition that there may be different dosing and different metabolism?
Of course.
Okay.
Yes, of course.
And then magnesium.
Yeah, and also for finish the answer, we have a problem that there are only 3 women in our study, because the proportion of men and women in the methadone maintenance programs is 3 to 7. So our samples is a representative sample of the reality. So probably it's needed to do more research with women in order to better study the different pharmacology and pharmacology.
You may have to do more targeted outreach for women if you need the numbers to show something. And then
magnesium, we didn't use it, but it's a usual practice. We didn't use it because we didn't have any problem. Nobody. Because
the dose was so low, it wasn't an issue?
Probably because the dose was so low. Yeah, we reached until 600 milligrams. Again, I don't know if there are more success in one group or in another. My intuition is that there are no difference between groups. And another important issue is that psychological effects of our patients were they were not quite dramatic. Not only because of the dose, but only because methadone reduce the psychological experience of psychedelics. And in fact, opioids is a very, I don't know if it's a very good medicine in order to stop a bad trip from psychedelics. And also methadone, in some way, numb the emotional expressions. So when, and also avoid people to experience the psychological effect. This is something that we have to do when we did the statistics. To look if at the time that they reduce the dose of methadone and they increase the dose of Ibogaine, they experience more psychological effects.
Okay, so this seems very important, this idea that maybe opiates are blunting a psychedelic effect, and maybe not just in Ibogaine. I mean, you know, this whole area of interactions between prescription meds and psychedelics is wide open to look at more. Somebody is asking if you can please put the last slide up again with your contact information, which you don't have to do, but you could do.
I don't know if I can. I don't have access now.
I mean, I feel like maybe the people that are back there maybe can put up. That looks like the slide we're asking for. Thank you so much. Dr. Bouso, are you comfortable talking about like kappa opioid receptors and how they may be involved here? With Ibogaine mechanism of action, is that part of the idea?
I don't think so. I think that the mechanism is more in the mu receptors. And this may explain the anti-addictive effect, but I don't think that this is the. Truly, we don't know. Some say that because it releases neurotrophic factors, maybe the neurotrophic factors restore the rewarding system, and so on. There are too many hypotheses and theories. Sincerely, I have no idea.
Well, I appreciate anyone who says they don't know in this situation, so I actually applaud you. Some people are asking if they can be involved in the research, but my assumption is that you are not recruiting for this study.
Well, we have just finished a study last Tuesday, so give me some time to recover, please.
Yeah. And someone rightfully is asking about, you know, what ICEERS does to protect the Tabernanthe shrub, Iboga. Can you talk about that a little bit?
Yeah, we have a program and a report. We have two collaborators, Ricard Faura, Ricard Faura was here in Horizons some years ago, and Andrea Lagnois, that I think that is a well-known figure in the women psychedelic scene, and they were doing field work in Gabon, and after that they published a report that can be found in the ICEERS webpage with some recommendations. First, explaining what is the situation of Iboga in Gabon and in Equatorial Guinea, and interviewing people. For example, there is an institution in Gabon who harvests Iboga from a sustainable way in order to produce Ibogaine for the rest of the world. And well, in this report, there are too many recommendations in order to avoid the extinction of Iboga. My recommendation is that Ibogaine providers use Ibogaine from Boakanga. This is difficult because, as I explained before, if we go from the polypharmacological point of view, maybe the whole plant could be more efficacy than the pure alkaloid. We don't know. We need to do. But this happens with Banisteriopsis capi, for example, in rat models of Parkinson. Is more efficient the extract of Banisteriopsis that has of the armin alkaloids that just armin. We don't know if this is true also with Ibogaine, but this is something that should be researched.
So just looking at isolated alkaloids versus sort of whole plant or the whole root, and you may get something different.
Yeah. So if you use the root, you are using Tabernanthe Iboga, and if you use Tabernanthe Iboga, be careful of obtaining it from a sustainable fund.
Right. Sustainability is important. Thank you, Dr. Bouso, José Carlos Bouso. It was great to see you.
Thank you.
Our next lecture is starting at 11:45 sharp. You have a little half hour to do whatever you're going to do, but please come back on time. We're going to be talking about hospice care.